Bismillah ar-Rahman ar-Rahim. Another new meeting of Egyptian Society of Nephrology and Transplantation online CB meetings. Welcome everybody to this meeting. We have today two great speakers and moderators from ASNT board. We have our great moderator today, Professor Kamal Okasha, Professor of Nephrology and Internal Medicine, Tanta University, Head of Nephrology team in Tanta University and the President of Tanta Nephrology Unit. And also he is the Vice President of Tanta University, as we all know. Professor Kamal is a well-known scientific Egyptian, African and international figures by his known publications and many publications in international journals and international conferences, in addition to his share in almost every Egyptian scientific activity all over the year. And our speaker is Professor Roushdy, Professor of Nephrology and Internal Medicine, Cairo University, the past president of Asr Al-Aini Nephrology Dialysis and Transplantation Center. Professor Mona is one of the ESNT board and one of the heavy scientific figures in Egypt and internationally, and she is one of now is working in Giza University as the head of internal medicine department. Proton pump inhibitors are important drugs, and I think no prescriptions or very little prescriptions are devoid of this drug. Are these drugs that useful? Are these drugs that safe, that we can continue for a long period of time? This what we will know, and their effect, useful and bad effects on the kidney today in today's lecture by Professor. Before I leave the floor, I want to thank our moderator today, Dr. Islam Abu Ni'ma, for his activity regarding this session and almost all his activities almost of the year with me in CB activities of Egyptian Society of Nephrology and Transplantation. So I will leave the floor to our great moderator today, Professor Kamal, which we are pleased really to have us today in this session, to lead this session and introduce more Professor Mona and listen to her lecture and enjoy the, for sure, heavy scientific discussion by the end. Professor Kamal, please take the floor.
Thank you very much, Dr. Yasser, for this very nice introduction. Yeah, thank you very much. And thank you very much for your consistent, perseverance and support for the CME activity for the ESNT Zoom meeting. And today we have one of the eminent figures of nephrology in Egypt, and she's one of the board members of executive board member of ESNT. Welcome, Dr. Mona, Professor Mona Roushdy, Professor of Nephrology, Cairo University. And it's my pleasure to have with us eminent figures of nephrology. Professor Saeed is with us so far right now. And you hear me? You hear me? Yeah.
Yes.
Welcome, Dr. Saeed, for you almost enriched the discussion for all scientific events that we have. Yeah, you are a big add to this event.
Thank you.
Dr.
Thank you.
Yes, thank you very much again. Yes, sir. I'll pray for you just to continue this magnificent events that we share every week. Actually, thank you very much.
Thank you, Professor Kamal. Thank you.
Yeah,
Thank you.
I think today we have with us. I'm just inviting everybody just to share with us his knowledge and his information for this issue, which is very important, as Dr. Yasser said. Proton pump inhibitors and the kidneys. It's very important topics. It is, we'll take the pros and cons. Yes. So I'm sure that we'll have a very excellent talk from Dr. Mona, as we used to have from her. Please, Dr. Mona.
Thank you very much, Professor Dr. Kamal, for your kind introduction. I am very always thankful to Dr. Yasser to give me always the opportunity to share in the CME activity of ESNT. And I'm thankful also for Dr. Yasser because he chooses very very good topics, very updated topics, which usually lead to fruitful discussions and leads to better care of our patients. I will welcoming also all audience and all participants and waiting for their feedback after the lecture.
Thank you, Professor Mohan. Please go.
This is the outline of my lecture today. I will talk very briefly about the indications, the mechanism of action, drug interactions and dosing, and the potential complications, general complications of a proton pump inhibitor. But the main core of the lecture will be about PPI in the kidney. I will try to do a critical appraisal, navigate with you through all the studies, and critically analyze them to search for the evidence which was concluded from those studies. Then I will talk about the prescription of PPI. Then the last two slides about a new class of drugs, vonaprazan, which is a new drug we introduced, and it is used for the same indications of PPI in the peptic ulcer and the duodenal ulcer, and we will see if it is an alternative to the safe alternative for PPI or not. At the end of the lecture, I will discuss with you briefly four cases, very short cases, in order to try to think how can we deprescribe proton pump inhibitors in those patients. Proton pump inhibitors is a class of drugs that leads to reduce the gastric acid secretion by irreversibly binding to proton pump ATPase enzyme in the stomach. Their effectiveness as an acid suppressing therapy has led to their prescribed to be one of the most commonly prescribed medications. The first drug appeared in the market in 1988. It was omeprazole. Then in 2015, further 6 drugs were approved from the FDA, and they are all available in the market: omeprazole, esomeprazole, lanzo, and dexlansoprazole, pantoprazole, and rabipirazole. We have to note that the doses differ in those drugs according to the indication and according to the molecule. This table is quoted from the up-to-date. It shows that the different molecules have different doses and also in different indication, and we have to note that they have to be administered daily before breakfast. This is a precaution to all of them, although sometimes claimed that some of them can be used without, it doesn't interfere with food or is not interfered with food. These are the indications of PPI according to the last guidelines issued 2022 from the American Gastroenterology Association. I posted this slide in order to see what are the definite indication and when they are not indicated. If we look to the definite indication are H. pylori eradication, stress ulceration, ICU patients, uninvestigated GERD, or treatment of non-steroidal anti-inflammatory related gastric and duodenal peptic ulcers. But I want you to have also a look to the non-indication. It is not indicated as an empiric treatment in laryngopharyngeal symptomatology or any abdominal pain undifferentiated or in the presence of acute nausea and vomiting, GERD and esophagitis, believed to be related to GERD or esophagitis, and isolated lower GIT symptomatology. Most of prescriptions of all physicians in any specialty, they give it empirically in non-indication, and so we have to concentrate about the indication, whether short-term or long-term. And these are the indications. In the long term, they are indicated in specific conditions. And this slide of this reference will be very useful for us in deep prescription, actually, because the first point in deep prescription, we have to know we have to assess the patient and know the exact indication for which PPI is prescribed. This is to revise the mechanism of action of all acid-lowering drugs, the proton pump inhibitors. irreversibly hydrogen potassium ATPase enzyme, so they release they doesn't release the proton into the gastric lumen, and so they lead to reduced gastric acidity. While the H2 blocker act on histamine receptors, the new drugs I talked about in the introduction, it is a recent group of drugs. It doesn't act on hydrogen base, it acts on potassium channel, and so they are effective, they are efficient, they are more effective even at proton pump. We have to pay attention about also the drug interactions. There is several drug interactions associated with PPI. It leads to decreased activity of clopidogrel and leads to decreased anticoagulant and antiplatelet action. It decreases the activity of theophylline and HIV protein. Okay. We talked about the drug interactions. We have also to pay attention of prescriptions of PPI in older adults because older adults have, although the bioavailability is largely intact, but they can have, they might have reduced hepatic and renal blood flow and reduction of the glomerular filtration rate. So the drug levels may be higher, and also they have decline in albumin levels. The effects are compounded also by the presence of multiple morbidity and polypharmacy. So these patients will have a combination of prescribed and over-the-counter drugs. So they may lead to drug and drug nutrients and drug disease interactions. And we have to note that the proton pump inhibitors is one of these polypharmacy, which is frequently not indicated. If you have a look to this slide shows general potential complications of PPI use, and I insist on saying potential complications because of their widespread use. They may be associated by many symptoms. So one of the most famous, and also there is a warning of FDA against it, is the hypomagnesemia. Then also there is the rebound hypergastrinemia, where there is increased gastrin level, which carries the potential or the fears that it may lead to fundic polyps or neoplasm. It also leads to increased infections, either pulmonary or also by Clostridium difficile due to altering of the gastric pH. It leads to vitamin B deficiency. It may be potentially complicated by vitamin B12 deficiency, and osteoporosis is one of the famous complications or the alerts or potential complications for PPI use. Even the patients, there were papers lately about the higher risk of COVID infections in patients taking PPI, and also PPI use may increase the risk of composite poor outcome. So as we see, it is incriminated in many complications and in many diseases, but we have to appraise and we have to navigate the studies in order to know if it is an association only, or it is a cause of these complications. This is the main core of the presentation today, which is the PPI and the kidney. I will talk about hypomagnesemia, acute interstitial nephritis, CKD, and progression of CKD, and all-cause mortality in patients with CKD. If we see this meta-analysis, this is a recent meta-analysis published in 2019. It shows that the results, it included many observational studies actually, and it shows that there is a dose response between the PPI and development of hypomagnesemia. As we can see here, the odds ratio is for development of hypomagnesemia in patients taking PPI even after adjustment of many variables, and I will talk about this adjustment if these factors are still influencing the patient or not later in this lecture. But if you look at all the studies, here we find the adjusted odds ratio above 1, it's 2.5 and sometimes 4, so it is significant for increased incidence of hypomagnesemia in patients with PPI use. Regarding the mechanism of hypomagnesemia, it is largely unknown, but it may in the most of the study, it may the evidence supports the intestinal loss rather than the urinary loss, as the urinary magnesium was not increased. Furthermore, you have to observe that some patients with genetic variability, they can have a decreased magnesium absorption or decreased intestinal absorption of magnesium, and so these patients are more susceptible to hypomagnesemia by the use of PPI. It goes without saying that elderly patients are also susceptible, especially with nutritional deficiency. Patients on diuretics may be susceptible also. So there are many people who are susceptible more than others and should take special attention. In 2011, the FDA issued a drug safety announcement to inform the public that prescription of PPI may lead to low serum magnesium levels, hypomagnesemia if taken for prolonged period in most cases. So the duration here is the factor. The longer the duration, the more the patient is susceptible, and the patient should stop. Patients who develops hypomagnesemia should stop the PPI use because it is not corrected by magnesium supplementation. We move to the next claimed association or suggested association or complication. The first case which was recorded with acute kidney injury with PPI appeared in the American Journal of Medicine in 1992. It was described in a 74-year-old woman who was admitted to the hospital with rising serum creatinine. The picture was the same picture as acute interstitial nephritis in any patient, drug reaction, and the patient, after stopping the treatment, the patient developed a gradual improvement in serum creatinine and was discharged. After this study, there are several case reports which appeared in the following years. This study was published in Kidney International in 2014, and it is a nested case controlled studies, included 572,000 patients without history of interstitial disease, patients were collected between 2005 and 2009. Cases has a first diagnosis after cohort entry of acute interstitial nephritis and the confirmed by hospital discharge letter or death record or renal histology or without a renal biopsy. And this study shows it was differentiating between two variables. First, the dose, and second, the current use versus past use. And here you take a look of the results. The results shows that the patients with current use or recent use are more susceptible. The incidence is higher in patients taking it currently rather than past use. And here these are the proton pump used, and the low dose and standard dose and high dose are specified for every type of proton pump, as I mentioned earlier, that the dose is variable according to the molecule itself. Here, this is also from the results of the study. I wanted to draw your attention also about the age. Here, the higher the age, the higher the incidence. From 60 to 69, we find here 19 cases. In comparison to other age groups, it is a higher incidence, I mean. The investigator developed a nested case control study and provided evidence for increased risk for acute interstitial nephritis among current PPI users versus an active comparator control of past PPI. In this study, they compared both people were taking PPI actually, as in other studies, they compared sometimes PPI with H2 blockers, but they compared both groups taking both PPI, but current versus old. And so an active comparator control of past PPI users to some extent lessening concerns about confounding by indication because both groups receive PPI and providing evidence for temporality. Temporality is very important word in assessing or in assessing association, causality versus association. So if a drug is a cause of a complication, it may satisfy this condition of temporality. We will see this in a special scoring system, which states that temporality is an important factor in assessing or in stating that the drug is the cause of this complication. So this is another study which shows also that the incidence of acute interstitial nephritis, it was compared in two groups, PPI users versus non-PPI users and PPI users versus proton pump blocker users. However, the strength, as we see here at the end, at the very end of the table, the strength of evidence, it is described as being insufficient. And also it is described as being low in the other group of studies in this meta-analysis. What is the mechanism by which PPI cause acute interstitial nephritis? It is as a result of cell-mediated immune response, possibly idiosyncratic and likely characterized as dose-dependent. It has been reported that 30–70% of patients with acute interstitial nephritis did not achieve complete kidney recovery after the discontinuation of PPI. It is speculated sometimes that it is undiagnosed or unrecognized, and partial recovery may lead to subsequent CKD among PPI users. It is also there is the characteristic feature of acute interstitial nephritis that it is not presenting by the characteristic triad C in hypersensitivity reaction with fever, skin rash, and eosinophilia. No, it doesn't show these triad. So it is difficult to, it is not easily diagnosed, I mean, like other drug reaction. Urinary findings include sterile leukocyturia, hematuria, urinary eosinophils, and diagnosis is based usually on lab and imaging and clinical examination and test. That's why the test doesn't lead to accurate diagnosis. This was about hypomagnesemia and acute kidney injury, and now I will talk about the risk of instant CKD and CKD progression with PPI. In the following slides, I will talk about the general weaknesses of most of the study. And then I will select some studies to show you the application of these weaknesses, how these weaknesses are applied or can be explained or criticized in the several papers. So the general problem in all papers talking about CKD or CKD progression in PPI is that they are large observational studies. As a source of studies, they are observational, and generalized findings. Patient should consider the Bradford-Hill criteria for causal association. What are the Bradford-Hill criteria for causal association? These criteria were invented, or they are prepared by Bradford-Hill, and they are 9 criteria. They should be present in order to state or to confirm that this drug causes this reaction, causes this side effect or complication. These points are the strength of association, the consistency, the specificity, the temporality. I talked before about the temporality, the biologic gradient, the biologic plausibility, the coherence, and the experiment and the analogy. Analogy is the specific features, for example, which are caused by specific drug. So if we apply these criteria on the complications of any complications of proton pump inhibitor, for example, here in the red boxes, the acute interstitial nephritis and renal failure, we see that the strength in most of the studies is weak, and the temporality is the only item which is satisfied or which is completed in these studies. That temporality means that this complication occurred at the same time of the drug intake. So the strength of the evidence is not very definite that they are associated with these complications. They are associated, I mean, they don't cause these complications. So this is the difference. Also, there are, beside this association or causality, there are several confounding factors, such as other concomitant exposure to nephrotoxic drugs, as the same patient may be taking nephrotoxic drugs, and we'll see in the studies that sometimes the study doesn't state or doesn't write or doesn't ask for any drugs or nephrotoxic drugs taken by the patient, especially there were elderly patients in this cohort group. Patient comorbidities are also may lead also to the same complications. Race, sex, and age group, all factors, they need to be considered. There is the problem also as residual confounding. I would like to explain the term residual confounding because in some papers, when you read the paper, they tell you or they write that they adjusted all other factors. For example, they adjusted for the age, they adjusted for comorbid condition, for diabetes, for hypertension, and so on. But there is still in these papers residual confounding. What is the residual confounding? Residual confounding is that the confounding factor is measured imperfectly or with some errors. So we cannot completely, when we adjust for it, it doesn't completely remove the effect of the confounding variable. For example, that the comorbid status, or even if we adjust for it, it leads to impairment of the health of the patient, for example. So it also confounded the results and may lead to morbidity. The central question is whether the observed positive association are due to the effect of PPI or the reasons why it is prescribed. They are usually prescribed for patients with worse overall health status. They used in patients with multiple comorbidities. And so there are many confounding factors that even if adjusted, they can influence the result. Okay. And the third problem in all, these are general remarks, the presence, the problem of absolute or relative risk for adverse effects. Long-term PPI, when the study measure the relative risk or odds ratio, this is the ratio between the cases in the affected cases and the cases in the control, but doesn't state this the absolute number. For example, if we take here the presence of chronic kidney disease in a study by Lazarus et al. I will take the study then with some detail later. We found that the relative risk between the two groups is 10% to 20% increase, while the absolute excess risk is 0.1% to 0.3% per patient per year. So we have to understand the difference between absolute risk and relative risk. So these all factors or all statistical explanations are general comments on the paper or the studies. When we navigate the studies, we have to take them into consideration in order to understand it is an association or a causality. There is problems in the studies itself, that they was unable to determine the quantity or duration. I will show you the studies then later on. Sometimes they depend on prescriptions by the health, for example, health insurance, for example, or by self-report. The patient reports what he took from PPI, and so they were not precise in stating the duration and the dosing. And the association between duration, exposure, and risk of renal outcome was not also uniform in all studies. So that in a study, the risk of renal outcomes diminished after more 720 days, for example. So before taking the studies into some detail, I will tell you about the proposed mechanisms of chronic complications of PPI therapy. One proposed mechanism is the unresolved acute interstitial nephritis. After the recurrent attacks of acute interstitial nephritis, the patient may not return to the normal baseline level creatinine, and it may lead to chronic interstitial nephritis and chronic kidney disease. These acute kidney interstitial nephritis may be undiagnosed, as we mentioned before. Another hypothesis is the presence of altered gut microbial composition and metabolism may be the causal pathway between PPIs and CKD, and also hypomagnesemia may share in the development of CKD. This slide shows a summary of all the pathogenetic proposed pathogenetic mechanism is that the position of PPIs metabolized in the tubular interstitium may lead to immune response, interstitial inflammatory infiltrate and edema. This may lead to acute interstitial nephritis and acute kidney injury together with interstitial fibrosis. This is helped also by hypomagnesemia and all lead to chronic kidney disease and end-stage renal disease. After the summary I made about the statistical problems in the studies and the type of studies and all the comments about the studies, I will take some examples from the actually famous studies done about proton pump inhibitors. This study was done by Lazarus in 2000, was published in JAMA in 2016. It included 10,482 participants in the atherosclerosis risk in community study. And there was another cohort, the study was replicated or repeated in the Geisinger health system. The exposure was self-reported PPI. As I mentioned, it is not very precise, and the dose and duration was not assessed, and it was compared to patients taking histamine 2 receptor, and the main outcome measure is the incidence CKD diagnostic code at hospital discharge was taken and defined as less than CKD if they have less than 60 milliliter per minute. If you look to the column to the left, to the graph to the left, I wanted to only to show you between 2006 and 2011 the rise of use of PPI, the prevalence of event. There is increased use from 2006 to 2011, very much higher use, and as we see here from the other graph, the hazard ratio to CKD in patients taking a proton pump inhibitor versus those taking H2 blocker. And the conclusion of this study was it was associated with 20 to 50% higher risk. As I told you before, or as you saw in the previous slide, it is relative risk in between two groups and is not an absolute risk. What the criticisms directed against this study is that it is that the patients were not well matched for the severity of their gastrointestinal disorders, as PPI are first-line therapy for more serious disorder, and patients with PPI group had higher rate of comorbidities. The diagnostic codes at hospital had limited sensitivity, and also the study didn't show increased risk in all patients. So it didn't show increased risk, or there was no increased risk in young patients or Black patients, women, diabetic patients on ACE or ARBs, and patients on diuretic. So the risk was not absolute. And in the other cohort study, they found no increased risk in young patients. This is another study done by Z et al. And published in a Journal of American Society of Nephrology in 2016. They took a cohort of patients and followed them up for 5 years. And so those patients compared with H2 blocker. So مش هقدر ارجعها تاني دقيقة واحدة. The renal PPI group compared with H2 blocker group had an increased risk of incident GFR less than 60 and incident CKD. Patient treated with PPI also had a significantly elevated risk of doubling of serum creatinine. The duration of PPI exposure and risk of renal outcome among those exposed to PPI compared with those exposed for less than 30. Yeah, there was a graded association. So there was increased risk with increased association, with increased duration. Two separate retrospective case control study designs were employed by Aurora, and it was published in the journal. The population included 99,269 patients, and the use was a questionnaire of yes or no. And demographic laboratory data, pre-PPI comorbidity variables, all was included in the study. They concluded that it is associated with increased risk of development of CKD and death. Limitations of this study are that they are one-time reading of GFR. The subgroup analysis found no increased risk in those who were older, women, Black, or diagnosed with diabetes, gastrointestinal disorder, vascular disease, or cancer, so the risk was not absolute. Concurrent medication used was not assessed, especially the use of non-steroidal anti-inflammatory drugs. We know that it may be the cause of the chronic kidney disease. Selective population, as this study didn't include females, and it was not, I forgot to tell in the other study to write that it is published in PMC Nephrology, published in 2016. Then this is the last study I think I mentioned. It is the study evaluated from 105,000 new PPI users, and it has a median follow-up of 27 years. They found that the new users of PPI were more likely to have a double serum creatinine or a 30% decrease in estimated GFR. But the criticisms are that the association is relatively weak. Here, the hazard ratio is 1.26 for both, but statistically significant in the primary analysis and subgroup analysis. Although one endpoint was a direct calculation, the other is only estimate of kidney function. Drug use and comorbidities were determined from administrative data and did not include over-the-counter drugs. PPI users are older, took more medications, including non-steroidal, had more comorbidities, and all factors that are also associated with chronic renal disease. One important note in this study, I want to draw your attention to, that there was less than 10,000 subjects taking H2 receptor antagonists compared to 105,000 subjects in the PPI group. This makes us to think about the frequency by which the drug is written. It is written almost 10 times the H2 blocker. The authors note that there is no current biological explanation for association of PPI with chronic kidney disease. This biological explanation is one of the criteria I mentioned before, the Bradford criteria I mentioned before for causality versus association. This is in a meta-analysis, and meta-analysis stated that the observational studies has low quality evidence. So the quality of evidence is low in most of the observational studies as stated in the systematic review. When we look to the studies with established CKD patients, yeah, the previous studies all were in patients who have normal kidney functions, and then they developed chronic kidney disease. But if we look to the chronic kidney disease patients, we find that the evidence is sparser when looking at patients with already established CKD. Grant published the results in 2019, documenting increased risk of doubling serum creatinine in end-stage kidney disease with PPI use. Then, similar to previously mentioned study, the PPI group were sicker and the control group comparing baseline characteristics. Concomitant medication, episodes of AKI, and hospitalization were not measured. Here, this is the results of meta-analysis. When we see the bottom, the column, and the bottom, the row of the bottom, PPI versus Proton versus H2 blocker, we find here that there is no statistical significance, p-value 0.53. So there is no statistical significance between both groups. Here we find that the use of PPI in CKD population was not associated with increased mortality or progression of end-stage renal disease when compared to H2 blocker and to no acid suppressing therapy. What is the cause of also PPI were studied for increased all-cause mortality and cause-specific mortality in CKD group. The causes of increased cause mortality may be attributed to hypomagnesemia. Also, PPI was an independent for all-cause mortality in CKD patients. It may be a predictor for cardiovascular mortality, and it the cardiovascular mortality were higher among patients on PPI than those with not on PPI. One limitation is lack information about the duration of exposure in this study, and therefore there is an intention to treat nature. In addition, measurement of total magnesium may have been overestimated the incidence of hypomagnesemia when significant hypoalbuminemia was present. Unmeasured confounders. As I mentioned before, the problem of residual confounding, the residual renal function, other factors are linked to poor prognosis, and in older patients such as malnutrition also may affect the result, and it was not stated in these studies. Only information in this study about nutrition is the serum albumin level, which was significantly lower in patients on PPI treatment before the study. It is also possible that PPI use is a marker for a frail population that has more comorbidity and polypharmacotherapy. These are also both studies about the mortality, increased risk of all-cause mortality due to CKD in PPI users versus H2 blocker use in 2017 and 2019. So in the previous slides, I highlighted the general problem of all studies, and I point to the weaknesses and the low quality of evidence of most of the studies, although the results were consistent. However, these results are very rapidly echoed in the social media, so that we see in the use heartburn meds associated with increased risk of kidney damage study finds, or in the Telegraph, heartburn drugs taken by million may increase the risk of early death study suggests. And so the patients, when an investigator asked the patient to know their awareness about the side effects of the drug, they found that 20% of patients were able to name at least one reported adverse effect. Among those side effects, CKD was the most common adverse event recalled both passively and actively. So many patients, or 46% of patients, were aware that they have the information that PPI may use CKD. 39% of patients had tried to stop PPI use without a provider recommendation, and patients with high risk for upper gastrointestinal bleeding were as likely as other patients to have attempted to stop PPI use. What I want to say is that the evidence is not very strong as we see. But it is consistent. So we cannot say to all patients, please stop the drug. There is many studies claiming that it leads to acute interstitial nephritis, hypomagnesemia, chronic kidney disease, and increased mortality. So please stop it. And also, the evidence suggests that there is a potential harm. So we have to apply the principle, the Hippocratic principle of primum non nocere, which is we have to stop harming the patient if there is a potential harm. This approach will likely result in minimizing harm and maximizing benefit. So we have to deprescribe PPI. What is the meaning of deprescription? Deprescription is defined as planned and supervised process stopping a medication or reducing its dose to improve the person's health or reduce the risk of adverse side effects, or when medication no longer providing benefit to the patient. Deprescribing can include stopping, stepping down by converting H2 blocker, or reducing doses to intermittent use or on-demand or use, or lowering the dose. Serious consideration should be given to addressing this in clinical encounter. So we have also to weigh the benefit and risk. Deep prescription has guidelines, so we have to apply the guidelines in the deep prescription and not deep prescribe for anybody. Absolutely. These deep prescription guidelines are the latest guidelines issued in Gastroenterology Journal, American Association of Gastroenterology in 2022. They state that all patients should have a regular review of the ongoing indication. So the first slides I showed you are revising the indication, and they have to document that indication. So the review should be the responsibility of the patient's primary care provider. Patients without a definitive indication should be considered for trial of deep prescribing. And most patients with an indication for chronic PPI use who take twice daily dosing should be considered to step down once daily PPI. There are some patients not for PPI discontinuation, as patients with complicated gastroesophageal reflux, history of severe erosive esophagitis, esophageal ulcer, peptic stricture should generally not be considered for PPI discontinuation. Patients with Barrett esophagus, eosinophilic esophagitis are not considered, should not be considered for a trial of deep prescribing. Patients with gastrointestinal bleeding risk should be assessed before the prescribing, should not be prescribed on no base. Patients with high risk for upper GIT bleeding should not be considered for the prescription. Patients who discontinue should be long-term PPI therapy should be advised that they may develop transient upper gastrointestinal symptoms due to rebound acid hypersecretion. Deep prescribing is either dose tapering or abrupt discontinuation can be considered. We will discuss this in the 4 cases I mentioned. Decision to discontinue PPI should be based solely on the lack of an indication of PPI use and not for the concern of the proton pump inhibitor adverse events. So there should be a lack of indication of PPI use to stop the drug. This slide summarizes it was published in the American Journal of Kidney Disease, but actually it summarizes all the information or the guidelines mentioned before. A patient with no indication should be stopped. Unknown indication on mild or moderate, we have to lower dose or stop on the use in demand, and monitor and follow up is very important for recurrence of symptoms. Patient with a peptic ulcer disease from non-steroidal or H. pylori treated for the specific time, 2 to 12 weeks should be stopped. Patients with upper GIT symptoms asymptomatic following treatment and ICU stress ulcer prophylaxis, uncomplicated and asymptomatic H. pylori infection treated for 2 weeks. All these patients should be stopped. But to the right of the diagram, we see that severe esophagitis, Barrett, and all the indication we mentioned before. And that's why it is very important to revise always the indication for which the drug is prescribed. Barriers to deprescribing. Before the presentation, there was some discussion of our valuable professors that the patients are very resistant to deprescribing. They believe that PPI improve the quality of life and values, and individuals may prefer intermittent or on-demand PPI therapy rather than stopping completely. There is always a fear of recurrence of symptoms. There is also a decreased or scarcity of quality evidence regarding discontinuation approaches. The dose reduction approach may be preferred by practitioners. There is unclear aspect for the frequency for follow-up after deprescription, after 4 to 12 weeks initially and less often thereafter. The one concern is the PPI-induced gastrin elevation secondary to hypoacidity and subsequent hypergastриnemia related rebound hyperacidity and dyspeptic symptoms following discontinuation of PPI. There are studies done on the prescription guidelines. We find that there is the step-down studies. In the step-down studies, we find the outcome is excellent. It is 76%, and the step-down was successful, as we can see, in 79.5%. Female gender was an independent predictor for successful step-down. if we, in studies with abrupt discontinuation, we find that the outcomes is not that good. It is 32% persisted daily PPI dosage, 43% reduced their doses, and discontinuation was successful in only 27%. And we see here that abrupt discontinuation was not, doesn't have as good result as the dose reduction. If we see here of the on-demand studies, we find that the on-demand studies was successful in 92% of cases, and here in other studies, it's 74% of cases and 69% of cases. So maybe on-demand studies, on-demand strategy may be successful in many cases. Alternatives, what to do to patients when we stop stepping down approach. We should prescribe H2 blockers, maybe considered instead. Some non-pharmacological interventions may be used because they have also been shown to ameliorate the symptoms, and these include attention to dietary or other triggers, weight loss, avoiding meals within 2 to 3 hours bedtime, and raising the head of the bed. Although we always tell the patient those instructions, but the patient doesn't, it is better or easier for him to take the drug than to do these instructions or advices. Monitoring, there is monitoring of kidney function of serum magnesium concentration. There is no evidence suggesting improved outcomes associated with monitoring of kidney functions and serum magnesium. But FDA warning, as I stated, for use of PPI for magnesium, patients to hypomagnesemia should receive a special attention, as I mentioned before. Last two slides is about vonoprazan. Vonoprazan is a new class of drug, acid-lowering drug. Actually, it is a potassium competitive acid blocker possessing a new mechanism of action. It is first approved in Japan in 2015, and it is now in the Egyptian market, and it is widely prescribed for many indications, as in eradication of H. pylori. It inhibits the acid secretion in the cells of gastric cells. The inhibitory effect is approximately 35 times greater than that of lansoprazole, so they are very effective. But how about what about their nephrotoxicity? Can we use them safely? This is a recent analysis which was published in the Kidney International in 2022, and it shows that it shows detected a safety signal for tubular interstitial nephritis induced by vonoprazan using a spontaneous adverse drug effect database in Japan. These findings indicate that vonoprazan might induce nephrotoxicity onset similar to that with the use of PPI. So it is not a very safe option, and we have to be also careful about it. So this was the presentation about the proton pump inhibitor. Now I will I have 4 cases to think about it. How can we deal with those patients? The first case is a 77-year-old woman with history of polymyalgia rheumatica, hypertension, osteoporosis, B12 deficiency, and type 2 diabetes. She was on omeprazole 40 milligrams for years for gastroesophageal reflux disease. Endoscopy recently confirmed gastritis and hiatal hernia. She is on risodronate, aspirin, and prednisolone, besides medications for hypertension and type 2 diabetes. PPI give her relief. What would be the approach to PPI use for her? Would you like to deprescribe, to stop, to continue? Okay. She is PPI for too long for diagnosis of hiatal hernia. If we revise the indications, she has perhaps non-responsive GERD. She has B12 deficiency, and osteoporosis may relate to PPI use. Low-dose steroids is not an indication for PPI therapy, so we have to discuss with her to taper it over weeks, or alternatively intermittent use to for specific periods of time. Rapidly, as case 2, she has a type 2 diabetes. She is 75-year-old. She has osteoarthritis, hypertension on insulin, angiotensin converting enzyme inhibitors, diuretics, antihypertensive, analgesics, including periodic non-steroidal. She has hemoglobin of 10. Ferritin and transferrin saturation are consistent with iron deficiency anemia. She finally undergoes colonoscopy, which is negative for upper endoscopy confirms a gastric ulcer. She is depressed from loss of her husband from COVID-19 and has not returned to the gastroenterologist. What be the role of PPI in the management? Should she continue PPI or should be de-prescribed? The problem of this patient that she is suffering from, she has anemia from ulcers and the ulcers are bleeding. So it is wise to de-prescribe or to stop PPI in this patient. The patient is anemic, upper endoscopy confirmed the gastric ulcer, she perhaps has mild upper GIT blood loss. So she must avoid non-steroidal anti-inflammatory, but if she insists on use, she is at high risk for bleeding. She is candidate for PPI prophylaxis as long as she is on non-steroidal anti-inflammatory drugs. So I like to comment on this case that every case should be personalized. We have to judge every case by itself. So this patient, we can never stop proton pump inhibitors because she has having actually bleeding. Case 3 is 85-year-old woman. She has gait abnormalities, cervical and lumbar stenosis. She has hypothyroidism, stage 3 chronic kidney disease, and history of falls. She has drugs, tramadol, ibuprofen, and lidocaine patch as needed. And she is on omeprazole 40 daily for more than a year. Hemoglobin is 10, transferrin saturation is 20. And she does not want to do any endoscopy. What is what to do with her PPIs? She has now she is stage 3 chronic kidney disease, and she is on non-steroidal anti-inflammatory drugs also. What to do? She has painful lumbosacral disease and uses non-steroidal, so she is at risk for more progression of CKD. And she has many factors, so she has to be prescribed regarding non-steroidal and both the omeprazole. She has discussions for surgery or physiotherapy as options in order to reduce both non-steroidal or proton pump inhibitors. The last case, the presentation was too long. This is the last case. Patient with hypertension, congestive heart failure, and peptic ulcer, underwent hospitalization and blood transfusion 6 months ago. She treated with pantoprazole and has a Helicobacter pylori eradication and continue to be on pantoprazole treatment. This is a very classic case. She has treatment for Helicobacter pylori and then she is continued on pantoprazole. She is admitted to the hospital for the primary care clinic following laboratory findings indicating an increase in serum creatinine from 1.4 to 5.4. During her hospital stay, serum creatinine continued to increase and peaked at 11. Workup revealed proteinuria, protein excretion of 700 milligrams per day, and kidney biopsy revealed diffuse acute interstitial nephritis and acute tubular injury. First, this patient was non-indicated for pantoprazole. The H. pylori treatment is only for 2 weeks, and she has to stop the treatment afterwards. This is probably a case of acute interstitial nephritis due to the proton pump inhibitor she took. And she should stop it immediately. And so we can see that in every case, there is the drug was stopped and the patient is treated with steroid regimen. So we can see that in every case, there is a different decision. Either we can continue on the drug, we have to stop the drug immediately, or we have to prescribe the drug very slowly. So the judge is the judge of the doctor in light of the indications and in light of the clinical situation of the patient. I hope it was not very long. Thank you very much.
Thank you very much, Professor Mona, for this excellent presentation, as usual. Thank you for clarification of everything that we are looking for to hear about from you about BBI and their bad effects on the kidney, as you've mentioned, very clearly. I really enjoyed your talk, and when you talked about the side effects and from the clinical case scenarios that you have mentioned, and the challenges that we have in clinical practice. You mentioned real cases actually that we have in clinical practice every day. I think if, Dr. Yasser, do we have any questions from the floor or from audience first?
Yes, we have a comment about the first case from Dr. Khalid Abu Zaid that describing on-demand strategy. He suggests describing on-demand strategy, cumulative and synergistic recovery. Requirements, percentage for renal biopsy in suspected acute interstitial nephritis due to PPI in the studies. يعني percent of renal biopsies. You said, Dr. Mona, that non-biopsied, as I remember.
There are some studies showing that there was a definite diagnosis by biopsy, and the others only they didn't do a renal biopsy. It is like any other acute interstitial nephritis treated as any other drug effect. Drug-induced acute interstitial nephritis. Not all drug-induced interstitial nephritis are biopsied. They are all so when suspicion of a drug reaction, we stop.
That's actually what I was going to talk about, that the indication for biopsy in this patient, actually exactly like any other patient you are suspecting kidney disease, unexplained kidney damage actually in any patient, so interstitial nephritis or maybe other acute kidney injury, for example, so I think it is the same like any other patient having unexplained kidney damage.
Yes, and
we have another
analysis and the presence of the presence of leukocytic pus cells in urine, or a very small amount of proteins, less than 1 gram. It is like all other acute interstitial nephritis. So the diagnosis is suspected like other, and if the patient, if after stopping the drug, the creatinine improves, so there is no need to do a biopsy, I think.
This is exactly like if you are suspecting, yes, why don't you go for renal biopsy? It's okay. I think we have another question actually for the H2 blockers actually. Somebody here who's Dr. Yasser, somebody is asking about
Dr. Ahmed Muhammad is asking that. Dr. Ahmed Muhammad is asking that H2 blockers also have side effects of acute interstitial nephritis. So what do you think safe alternative of these anti-acid drugs?
Of course, H2 blockers is an alternative for PPI in patients suffering interstitial nephritis or chronic kidney disease. But you just have to there is no this patient suffering something else, so you have to continue with PPI regardless the condition, with the lines of the Dr. Mona mentioned. If the patient has, for example, H2 pylori or bleeding or whatever, so I think at this case still PPI is to be used.
Yes, you are right. Fully right. Professor Dr. Kamal, this is what also stated in the guidelines of the
American,
American, for the indication, other than for the adverse effects. It is indicated or not. The problem is they are described and the patients continue on it.
Let me ask a question.
I have a question for please. Dr. Mona. Dr. Mona, Dr. Yasser, you're asking, please go ahead.
I have the question. I think that the first question in many minds, is it a class effect or related to the type of drug used?
Yes,
omeprazole, pantoprazole, esomeprazole. Is there a difference or the class effect?
Yes, I searched for this question because it is a question for everyone, for us. It is a very good question because every one of us wants to prescribe the safest drug. But most of the studies, either they mention only PPI, or they were done on omeprazole, the very at the start, the very early, studies. And then I showed you also the studies which included almost all of them, and it didn't. All the studies didn't make any difference between them. So there is probably a class effect. I didn't find this any difference between all of them. except in some pharmacokinetics that some of them have are more potent than the others, are the efficiency or the onset of action. Some have a more rapid onset of action, but I searched very thoroughly and didn't find regarding the side effects any differences between them.
I did. I did, Dr. Yasser. If you allow me, Dr. Yasser, Dr. Mana, I just searched for this very landmark trial and study, very long-term study, which was carried out between, it's like kind of meta-analysis from 2004 until 2019. According to the FDA Adverse Event Reporting System, they found very clearly that the most, one of the BBI is omeprazole, followed by lansoprazole, and surprisingly, dexlansoprazole was the strongest one amongst the BBI who has association with acute or chronic kidney disease. Surprisingly, as I mentioned, this is the one that dexlansoprazole, So
do you mean
the most popular of them is omeprazole because
the safest? The safest
no,
is
not safest. The
worst. The worst is omeprazole.
But according to this study, this is according, it is the FAERS, FAERS, FDA Adverse Event Reporting System. This is one of the biggest U.S. meta-analysis, which was carried from 2004 until 2019, and they studied the effect of 6 BBI on the acute kidney injury, chronic kidney disease, and surprisingly also they discuss it on the effect of BBI on the renal neoplasm. And that they found there is increased risk of renal neoplasm with the use of BBI. This is actually, I was surprised actually to hear about that. We heard earlier about the BBI and the risk of cancer of the stomach, but surprisingly, it is the effect on the kidney, renal neoplasm. They found some cases of hemangioma, some cases cystic disease, and some cases of non-specific renal cell carcinoma. I was astonished when I've heard about that. I'm not أنا ما بخوفش الناس إن هم يستخدموا الBBI, but دي data اللي هي فعلا اللي موجودة. If you allow me to send you the data, Dr. Mona and Dr. Yasser, it was really astonishing me and shocking actually at the same time.
Yes, please.
Yes. So the worst is omeprazole, and the safest.
I will send you that. It is this is there is kind of update every day. It's from FDA, so there is kind of update every day, kind of warning every day about the renal cancer, about the AKI, about the chronic kidney disease. Even in they found some cases of rhabdomyolysis related to the BBI in patient in this study. So it is a very long-term study. It's almost 15 years and still extended. They're still publishing some analysis until 2023 from this data, which was published on latestly from 2023, and the original one was published on 2021.
So Professor Kamal, to summarize, the worst, as you mentioned, is omeprazole.
Yes,
and
followed by lansoprazole, followed by dexlansoprazole. It is the strongest among them. Strongest dexlansoprazole.
Strongest regarding the GIT effect, huh?
Yes, regarding kidney damage.
You said that omeprazole is the worst. But
is the worst in general, yeah. But in this study, they found that lansoprazole in terms of AKI was the worst. And for chronic kidney disease, dexlansoprazole.
Okay. Professor Said Khamis.
Thank you, Professor Yasser. Thank you, Professor Kamal. And thank you, Professor Mona, for this very comprehensive review about this presentation about the BBI and the kidney or effect of the kidney. I do agree, I fully agree with all of you that we should prescribe, when indicated for sure, any drug, any unnecessarily prescribed drug. especially if the population or the people started to use these medication like the chocolates, and every now and then they go to the pharmacy and they take this over-the-counter medication. So it is very bad for our kidneys. I have just only two questions, if you allow me. Number one, regarding the dialysis patient and using this PPI. Also, there is an over-prescription of this medication to this dialysis patient. Is there any information or studies showing that these BBI, I mean the extrarenal for sure side effect, like fractures or this hypomagnesemia or hypercalcemia or whatever, in this dialysis patient compared to the non-uremic patient? That's number one. Number two, regarding the transplant patient, renal transplant patient or organ transplant patient, is there any drug-drug interaction with the other immunosuppressive medication like this MMF, or, for example, the hypomagnesemia occurred with cyclosporine? It is documented by this BBI or not? Thank you so much.
The drug interactions, I think those only what I mentioned, those only who are what I found about the proton pump inhibitors, which are the clopidogrel and aspirin, and so the anticoagulants I mentioned in my presentation.
Yeah, I remember. Yeah, at the beginning of the
interactions I found about them. Okay, but the risk of hypomagnesemia is present if the patient is taking any diuretic, is present, and in elderly patient it is present in any patient, so it will be present also in transplanted patients as well.
Yeah. And what about the dialysis patient? It is the same, I mean, side effects, or it will be augmented or increased regarding the non-uremic patient?
There is also alteration in patients with hemodialysis. There is also electrolyte imbalance, especially hypomagnesemia, and this is also can also occur in patients with hemodialysis, but the effect is not also clear cut, because they have many comorbidities also, because they are hypoalbuminic and so on.
Yeah.
There is also evidence of reduced bone densities and all the complications. But to be compared, actually, when I was working under the director of the dialysis center in Qasr Al Aini, I tried very hard to de-prescribe it from patients, because many of them suffered fractures, and the osteoporosis. Yes, and it was very. There were many studies about the osteoporosis and so on, and I tried to prescribe them. It is very difficult to de-prescribe, especially in patients with on hemodialysis. But actually, they have the same risks and even the increased mortality risk. But the evidence is not very high. The strength of evidence is not high as well as the CKD patients. But there is no studies comparing, both, it's all observations studies. There is no case control studies between both patients.
Okay, thank you so much, Professor. Thank you.
For transplant side, there are just very few studies just showing the effect of BBI, and this one, I'm going to send it to you. One is published in 2019, just talking about the effect of BBI in kidney transplant patient. They found no significant difference between patient using BBI and non-BBI user among kidney transplant. There is no significant effect on the incidence of graft acute rejection, graft loss, or chronic even allograft nephropathy. So this is, just very few studies for that effect. Yeah, I'm going to send it to you, the one that I have for the BBI and transplant recipient.
Okay, thank you, Professor Kamal. Thank you, Professor Mona. Thank you.
We have some questions on the chat. Dr. Masoud Khairi, is there a genetic variation for PPI associated interstitial nephritis? Is it linked to any genetic variants or something like this?
No, a genetic variance only for hypomagnesemia, I found. Dr. Kamal, did you find any genetic variants?
Yes, for hypomagnesemia, yes.
Magnesemia only, yes.
Yeah.
From Dr. Khaled Abu Zaid, when biopsy should be done and when steroids should be added. I think it's the same as interstitial nephritis.
It's the same as any drug-induced acute interstitial nephritis.
Again, a question. I think the safest, he is commenting, the safest drug is to use sacralfate in this case, but
But according to the guidelines, they have an indication. Proton pump inhibitors still have an indication.
I don't think that sacralfate is that strong as PPIs, especially now the era is PPIs regarding it was used in the past in GIT bleedings, and but I don't think that it will have the same effect in bleeding ulcers or similar conditions.
We have been using it as we were at our residency. When
yes. Vonoprazan not studied yet very well, so you still can use it unless you find something or related adverse event for vonoprazan. So we can still use that one, vonoprazan. And just remind you, Dr. Mona and Dr. Yasser, you remember the era of cytoprotective drugs, like
yes.
Use a
but
line.
Now I find these drugs helpful in non-steroidal induced gastroesophageal reflux.
Because most of prostaglandin, basically.
Yes. I find them to be useful in the cases of heavy use of non-steroidal anti-inflammatory drug associated with GERD manifestations.
Yes.
And for the effect of the kidney, I don't know really if they have a bad effect of the kidney, but as far as I remember, they do not have such like this.
No, I think and are safe for the kidney anyway. And it's just it's the renal vasodilator.
Again, a question. Again, a question from Dr. Khaled Abu Zaid. Your explanation of persistent and resistant hypomagnesemia due to IV PPI, even after storage of the drug.
Not after stoppage of the drug. I mean, after without even with supplementation. Even the FDA states that even if you supplement magnesium, it will the patient will still suffer from hypomagnesemia. It will not be corrected. You have to stop the drug. This is the statement of the FDA.
Yes, I find I met a case like this, and there was resistant hypomagnesemia, and really improved after stoppage of PPI somewhat.
This is very important. Yes, actually, because hypomagnesemia is one of the strongest predictor for vascular calcification. So if you find it, we have just to find out the reason. If it is BBI, for sure, gonna discontinue.
Yes, and I remember a case for one of our colleagues of inducing TMA by the use of single tablet of this drug. I don't know if you have a similar case report you have met Dr. Ramona during your search, but it was reported and recorded that he suffered a TMA due to single tablet of this drug due to abdominal discomfort, and suffered lot of problems later on.
Dr. Yasser, even those patients with rhabdomyolysis in that large study, they found that it's maybe due to other simultaneous use of other medications, which was accused to do rhabdomyolysis, for example, statin. So we have to find out first, maybe other drugs. So just review of medication is very important.
Yes, of course. Polymedication is really a problem. Dr. Ghada Subhi asked a question about the safe. You mentioned, Dr. Kamal, that the worst is omeprazole, Dexa, and Lance. But she is asking about the safest one. And as far as I remember, you did not mention anything about esomeprazole. Bad effect of esomeprazole, one of the worst or something like this. Or do you have a report, one that's considered the safest?
No, Dr. Yasser,
ESMO not mentioned.
As long as it's not mentioned, it's just very large trials. So I think it's safe. So So it's not mentioned here. This is the among six BBI that being used, as I mentioned, omeprazole, lansoprazole, and lansoprazole. So those are the three who are accused in the very significant side effects among chronic kidney disease, acute kidney injury, or even those with very descriptive cases of neoplasm or rhabdomyolysis.
So we cannot say have an answer for the safest, but we can say that esomeprazole, pantoprazole are not mentioned among the worst.
Yes, are not mentioned. No,
Yes.
mentioned. Yes, exactly.
You have to consider also that omeprazole is the oldest. It was discovered in 1988, and so it is present in all the old. Yani, omeprazole was the oldest one, which was present since 1988. So the most of the studies, old studies, was including omeprazole, and so it appears, I think, for to being unsafe if compared to the others. I mean, if they didn't talk about it. And omeprazole is stated in the case of acute interstitial nephritis, which was described in 1992. I only want to say that if the others are not mentioned, maybe they are not very safe, but because the studies included the older ones, maybe this.
Of course, this was observed in all of the studies addressing the old drugs. They have the major side effects and are linked to these drugs, and they said finally it may be due to the longer term of use. زي ما احنا بنقول اشتغل كتير تغلط كتير.
Yes, because they are widely described. Especially till now, we are talking about association or causality. So they are associated because they are widely prescribed. If I showed you that if we take the ratio, so 10,000 patients taking H2 blocker, there are 105,000 taking proton pump blockers. So they are widely used, widely prescribed since 1988.
Okay.
They were approved in 2015.
15 years. Yes, I remember the era of introduction of these drugs while we were starting our career in medicine. They were recently discovered, and was only the one present is omeprazole, and was even known by one product name only was present at the time in the market.
One company,
before,
which is
one product and one company.
Yeah.
Not like now the widest drugs and the widest varieties of drugs.
You remember Dr. Yasser was national company.
Yes. This is the one. This was the soul for these drugs at that time. From Dr. Massa Opey.
First drug.
Sorry.
Drug. So, as long as you are away from omeprazole, lansoprazole, and dexlansoprazole, I think the others you feel free to use it.
Yes, the remaining I think is esomeprazole and pantoprazole.
Yeah. Yes.
From Dr. Massa Opey, and I hope that I am pronouncing the name in a correct way. She is asking the second famous question: is this effect on the kidney is dose dependent or at any doses?
Most of the studies stated that it is a duration dependent. Most of the studies say it's a matter of duration, but they didn't state specific duration. But we can return to the first statement or the important statement to give the patient the indication, the duration, and upon the indication. If the indication for H. pylori is 2 weeks, then we have to stop them by 2 weeks.
Yeah. Related more to the duration.
Yes.
And I think there is no wide variety of the doses used. Most of us uses a common dose for each of them. Rare to have lower doses or higher doses in certain conditions, but in most of situations we use a single daily dose of single dose.
Yes, the guidelines recommend that we use the least dose, the least doses during the prescribing. I mean, not during the main indication. And after the indication, if we try to de-prescribe, we have to use the least dose.
Okay. And Professor Kamal, no more questions on the chat and no more comments. And excuse me to close, and you can close, please. as we have
That's
now more than one and a half hours that passed smoothly, very smoothly.
it's very nice. Yeah, very nice talk from
Yes.
Dr. Actually, very illustrative. Actually, everything related to the BBI and the kidney. I think. Thank you, Dr. Mona, and thank you, Dr. Yasser, for if you one who chose this one. Thank you very much again for the good choice for the topic. Actually, just it touches a lot of clinical practice for everyone at session. Yeah, and thank you all the attendees actually for sharing with us experience and your questions, which enriches the discussion. Thanks again, Dr. Mona. Thanks, everyone. Thanks, and Dr. Saeed, Dr. Faisal, Dr. Masoud, and Dr. Huda Al-Maghrabi, Dr. Safa.
Thank you, Professor Kamal, for mentioning all our attendees. And
Thank
we
you.
have more and more that most of them left now by the end of the session.
Yeah.
And thank you for your share with us
So
today.
that large,
Uh,
we'll send it to you.
Yes, please.
please, thank you. Yes,
Thank
please,
you.
Professor Kamal.
Thank you very much.
Thank you.
Thank you
And I would
again.
like, before I close, I would like to thank you, Professor Kamal, for leading this session.
Thank you.
And
Thank
thank you, Professor Mona, for this very illustrative, clinically directed, and to the point, really talk that was targeted to this important drug and used in the polymedication states. Excuse me to close this session and announce about the coming session, coming Wednesday. Will be Dr. Ziad Zaki from Cleveland Clinic speaking about biomarkers in kidney transplantation. Thank you for you all. وتصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
الله وبركاته. Thank you very much.
شكرا دكتور ياسر.